Hello, thank you for joining today's webinar. This is John Howlett with Kaufman Hall, and here with me is Debra Ryan, a Vice President with our Strategic Financial Planning team. Ms. Ryan has extensive experience in healthcare administration on both the provider and payer sides of the business. Along with contracting, her areas of focus and expertise include clinical integration program development, health plan operations, medical cost data analysis, and physician-provider network development in both commercial and government programs. Before we get into the presentation, I want to quickly review a few housekeeping items. Whether you're listening through your computer or via the conference line, all attendees will be in listen-only mode for the duration of the webinar. Those participating through their computer have the ability to send questions to us through the questions pane on your attendee interface. Simply type in your question and click send. At the end of the presentation, we will answer as many questions as we have time for. If your question is not addressed during Q&A, we will be sure to follow up with you afterward. Please note that material related to the issues we'll be covering today is accessible within the handouts area of the attendee interface. And as a final note, today's webinar is being recorded. All registrants will receive a follow-up email later this week with a link to view the recording. With that, I'll turn it over to Debra Ryan.
Thank you, John, for that great introduction, and welcome to everyone. The first part of the presentation today will be going over what's currently happening in value-based contracting, just sort of to level set. Then I'll go into best practices in contract review and negotiations, a little bit about the challenges, and then we'll open it up for questions. So the current state of affairs. Value-based contract definition varies significantly by payer and by market. Ranges are simple pay for performance programs to full risk and or percent of premium contracts. The common elements in value-based contracts are a requirement to meet or exceed specified criteria in order to receive a portion of revenue. And the criteria can be in your quality, in your efficiency metrics, and in your cost equation. And then the second part is a reduction in healthcare costs for a population. So contracts can vary by segment, so you can have a commercial product, you can have a Medicare, and usually those cost reductions look at the specific segment of the market. The majority of contracts, except in a few pockets of the country, such as California, a little bit in Colorado, Illinois, are still fee-for-service, and where value-based exists, they are usually retroactive programs with a review and payment adjustment. There's a reconciliation after the fact. So you don't have a lot of opportunities up front to control the costs. You need to be vigilant in monitoring the data and doing it on the back end. Success under any contract model requires core competencies and approaches. There has been a bit of a retreat of payers offering value-based in some markets that we've seen in our consulting work across the country, and that's based on both payers and providers lacking structural and operational capabilities related to the party's ability to enter into and manage value-based contracts. And this it's evident in the contract language. So there's typically vague contract terms and participation requirements. There's a lack of flexibility on the payer side, sometimes on the provider side, in modifying processes such as utilization management to accommodate desired referral processes. When you see those kinds of language provisions or have those kinds of discussions, that's usually the reason is that there's some structural deficiency at the payer and able to monitor and operationalize those programs to make it work well. And in those markets where that is happening, the payers have sometimes shifted away from value-based strictly to a pay-for-performance and out of more of the shared savings contracts. The other thing is contracts are becoming longer and more complicated, as are the affiliated materials such as provider manuals and policies. The other issue with those related materials are they often are changed unilaterally by the payer, sometimes on a monthly basis, often on a monthly basis, and they could have revenue or cost ramifications. There currently is a wide range of reimbursement alternatives. Markets offer a variety of choice based on payer, providers, cost, capabilities, and sophistication. Most contracts that I've looked at, and I've looked at probably 500 or so in the last 3 years, are a combination of one or more reimbursement mechanisms in the same contract. Naming, and you need to remember too that the naming conventions of contracts don't necessarily mean the same thing from payer to payer. So when you're evaluating, you need to pay attention to what the structure actually is and what it actually means. So the diagram on the bottom of this page shows the continuum from fee-for-service to a full provider-based health plan. There's different risks associated in these different models. Most of what we're seeing today are incentive-based fee-for-service. There's some pay-for-performance. I don't see many contracts with withholds. Bundled payments is becoming more and more prominent as CMS is rolling out some of those bundled initiatives and people are getting experience with those. Partial risk and full risk. Full risk is primarily, I'm seeing that primarily in the Southern California market with their Knox-Keene laws. Those structures, the provider group taking those Knox-Keene licenses will have the full risk. There's some partial risk with shared savings. A lot of organizations are doing the MSSP-ACO, which is a partial risk and a shared savings model. The current contract structures, so the duration is usually 2 to 5 years, and the shared savings contract sits on top of the current legacy fee-for-service contracts. So typically in these contracts, in the shared savings contract, there is a requirement that the providers and affiliated physicians continue to hold contracts, direct contracts with the payers. This is usually a retroactive process, and it sits on top. So you also have to have a entity that's capable of entering into contracts for that shared savings piece, and if it's upside or downside, be able to repay money if there's downside risk, and be able to distribute the money to the participants. And each state has differing laws regarding what the requirements are. So depending where you are, you need to make sure that you take a look at your state laws to find out what the requisite organizational structures are in order to participate in these kinds of contracts. The early value-based contracts, probably from like 10 or 12 years ago, did provide for infrastructure funding for care coordination activities, usually for a limited time period. More and more these provisions are going away as the payers, I'm assuming, believe you already have that infrastructure built. And the other thing you need to watch on those kinds of, if they are offered that infrastructure funding, is typically those are subtracted from the shared savings calculation. So it's really not a funding more than it's a loan for you to help you get your infrastructure set up. The ACO shared savings models include attributed lives model, and the attribution methods vary widely. You have a cap, if you have an HMO model where you have an assigned or a selected primary care physician, that's one of the models. I'm seeing more and more PPO contracts that have gatekeeper functionality requirements in those contracts. Those are the best kinds of models. The other ones have usually a sequence of steps based off of claims data, primary care specialists, pharmacy, in order to determine who the patient should be attributed to based on usage. They have upside or downside risk, depending on an entity's risk tolerance and or perceived capabilities. If a payer doesn't think you can handle it, they're probably not going to offer you downside risk. And there's variability in the amount of risk that they will offer to you in terms of what the shared savings percentage is. The more risk you take, if you take downside, you can get usually a larger percent share of the shared savings. There's always a requirement for reduction in total per member per month spend for the attributed lives. There's efficiency targets for select services. They're usually high spend, presumably overutilized services. Typically it's ER usage, high-tech imaging, radiology, length of stay, admits. Those are the top 5 that I see in contracts. There's also quality measure targets. They use HCAHPS, HEDIS, and in some states, particularly Pennsylvania, there are a significant number of proprietary measures that are in use. Quality efficiency measures must be met to receive shared savings payment. I'll talk a little bit about that a bit later. And there may be different models by lines of business within a single contract. So it's not unusual to see a shared savings amendment for a fully insured population, a separate one for administrative services only, or ASO, a capitated one. You can have contracts that have 5 or 6 shared savings calculations, and the calculations are usually different within each of those amendments. On page 9, this is a display of what the payers are doing. Blue Shield it's sort of scaled based off of what their capabilities are. So Blue Cross Blue Shield, they're all locally controlled plans, so there's no consistency among the various Blue Cross Blue Shield plans. The Blue Cross Blue Shield Association has contracting guidelines for all plans. The multi-state Blues plans have standard operational model across the country. So Anthem's model across the country is consistent, but if you went to a Highmark or some of the other Illinois Blue Cross, those have totally different value-based models. Cigna is one of the companies that has a national approach. They have a collaborative care model, and as of January, they were in 29 states with 161 contracts. They started this program in 2008, and they're averaging 30 contracts a year. Their motto, or what they're putting out there, is together we're building a sustainable care system. So they are big on collaboration. And when I say they're big on collaboration, it's not just with the provider community, it's also with their employer community. So they share more data with providers and with employers than any other of the large insurers that I've seen. They focus on health improvement and risk management, and they do view themselves as being a partnering insurer. United Healthcare, they expect to more than double industry-leading accountable care contracts to $50 billion by the end of 2017. They have a variety of models ranging from primary care bonus programs to accountable care incentives. They are showing, their ACOs are showing promising results with a 4 to 4.5 point reduction in medical cost trend through a patient-centered medical home construct. They have more than 575 hospitals, 1,100 medical groups, and 75,000 physicians in these ACO models across the country. They do tend to have benefit-defined programs. So they have a new product, which is called the Nexus ACO, which is a benefit option. It's in 15 markets to self-funded employees. That's their product for 2017. Aetna also has a standardized model. They actually have 2 or 3 that they roll out across the country. A little bit different between the different markets, but they have the same ACO type structure. It's not as standardized as the Cigna one. On page 10, this is a slide we use in a lot of our presentations, and it's who will drive the market forward towards value. And this shows the differences in who's actually driving it. So when payers and employers lead, rates see more pressure and providers become reactionary. And that is where we are right now. Most of the initiatives that we're seeing are being driven by large employer mandates. There's markets where large employers have gone to payers and said, we want you to do reference pricing, we want you to do bundled payments, and if not, we're ready to take our business someplace else. So right now, the employers are driving the market. When providers lead, focus is placed on care delivery and network development, but that takes to move a market and to move a direction, that takes some consistent and thoughtful push forward, and we're not seeing that kind of innovation coming from the hospitals and the physicians at this time. On page 11, my favorite question, will the value-based programs be viable long-term? And despite proliferation of a lot of different models like ACOs, CINs, patient-centered medical homes, provider communication, collaboration, and behavior change haven't materialized on a broad basis across the care continuum. There's still a lot of fragmentation in most of my clients. When we do assessments, there's pieces of what's needed to be done, but they're not connected in any meaningful way. And there's not a process to roll out best practices across an organization. This is especially true in larger health systems where there's multiple hospitals, and they may be in different market settings. Benefit design has not dramatically changed. And that causes misalignment of incentives. So there's still open access networks. That's probably one of the biggest challenges. Patients want choice. Choice does not work well when you're trying to manage costs. But that's where we are as a society, and most of the CMS programs that are out there always maintain patient choice. So that's a challenge, and I haven't seen anyone come up with a good method yet for being able to take open access networks and make it work under a value-based contract. Retroactive medical management is also challenging. Hindsight's always marvelous, but it doesn't help you move forward on value-based. Effective patient attribution models have yet to be developed. If you look at the MSSP ACO, it's a moving target. Your quarterly reports, it's a moving target in terms of who your patients are. There's a lot of issues with the different methodologies. There's been studies that have debunked some of the methodologies. Right now, the payers are doing the best they can, given that we primarily have on the PPO side open access networks. Technology, data collection, reporting, while improving, are not yet robust or timely enough for the effective management of patient populations. Once again, we've got a lot of different systems that don't all talk to each other. The data is not standardized other than claims data. So it's really hard to understand what's actually happening with the patient and move those patients through the system the way they need to under a true population health program that will help you be successful. On page 12, continued, current value-based programs still represent a minority share of providers' overall reimbursement, and until it's a bigger chunk of the revenue, there's not a lot of effort is put into making sure that it works. It is expected that there'll continue to be mixed models, including a shift to bundled services. And the focus so far has been on low-hanging fruit, controlling costs of the chronic condition population. A model for reimbursement for preventing illness hasn't been developed. When I interview providers and payers, they all say, you know, we're not at the end game yet. We're still trying to figure out what we need to do. And in the meantime, they're not building the legacy, building the infrastructures to operationalize those kinds of processes because they don't know what it's going to look like. So right now, all of the value-based contracts that are out there have to fit into a legacy payer system, and then most of the, like the shared savings and the bundle is all done on the back end using the data that sits in the legacy system. So that presents challenges in terms of being able to advance a new model with a different way of reimbursement. They just don't have the system set up. So page 13 is just sort of a summary. In the current limitations, the end game isn't known, so we're stuck with the legacy system, and that's that's across providers and payers. The current contract models are being retrofitted into legacy systems for claims processing, quality measurement, and financial reporting. What is changing? Success is highly dependent on alignment with physicians and physician office staff. Depending on the payer, providers will need technology capabilities to assist with managing contract provisions, such as population health management components. Coding accuracy is key to success under value-based models. The efficiency metrics, the quality metrics are primarily based on claims data and on specific codes. And if you don't understand what those specifications are, you can't succeed under those models. Data sharing is critical to success. So the more data you have, the better off you are. There's challenges with getting data in a consistent format. I do hear a lot that the payer data is not that robust and it's not that good. And when I hear that, I remind the providers that the data that the payers are providing is data that you submitted on claims. So I think, both parties need to do a better job in terms of monitoring that data and understanding what's in it and making their, what do they need to actually change behaviors and change the population health. And so there definitely needs to be collaboration on understanding what those feeds are, where they're coming from, what the inclusions, exclusions are, in order so that you really have a good picture of what the data looks like and that you can then take that and develop your clinical protocols to get to the population health that you're looking for. And then what won't change, current coding requirements and structures will not be eliminated. They're needed for statistics, identification of service, acuity and calculations, the quality, all the quality metrics, all of those things are all based off of coding. So at this point, I'm going to go into best practices in contracting. So on page 15, I'm calling it Beyond Revenue Cycle. And contract rate and payment management through revenue cycle activities address a critical part of a contract modeling negotiation process. But the base contract language and nuanced wording in those base contracts, provider management policies, may have further implications for reimbursement and account for payment variances. And all those provider manuals and policies are always, anyone that does contracting, there's always a clause that says provider manuals, policies, by reference, part of the contract. So they are considered part of the contract, and they need to be treated as part of the contract in evaluation. It's critically important to understand the levers that payers have available to them to adjust reimbursement payments. So their payment policies, their newsletters that come out once a month that say they're going to change how they handle processing infusion, processing whatever, those are ways that they have to change what's in your rate pages on your contract. By changing a process, they can, put, guardrails around the service, so you have to get authorization in order to get paid. They can reduce payment through use of, modifiers or policies, and those are levers that they have at their disposal. And when you sign a contract that includes, by reference, all these other documents, you're agreeing that that's happening and that you understand what those levers are. It's also important to understand the contractually related provisions and implications of the relationship. So besides, usually in the contract you'll have, here's your rate pages, here are your, here's, our methodology for processing claims. There might be a section on authorizations, utilization review, and throughout the contract, there's usually references, cross-references to other pieces of the contract that can impact on what your actual reimbursement is. So there's an example of claims payment penalties for failure to comply with pre-authorization. It might be vaguely referenced in the rate or compensation sections, But your utilization section, either in the contract or in the provider manual, will have more detail, and that's the detail that can cause reductions in reimbursement. Value-based models such as retrospective bundled payment methodologies and shared savings that sit on top of existing fee create additional challenges and possible revenue risks. So an example is on the attribution models. Some contracts have attributed life minimums for participation and early termination penalty clauses. So if there's a minimum number of lives you have to have in order to be paid a shared savings, and you have in your market a couple large employers who are currently in that program, and that large employer decides to take his business elsewhere to a different payer, you could be at risk on that shared savings amount potential that you're thinking that you're going to receive. And the payers are not very forthcoming in letting you know who those employers are and what their effective date of renewal is. So when you're signing these contracts for 2 to 5 years, it's not a guarantee that you'll have those attributed lives, unless you're in a market where there's a huge number of lives and you're so far over the minimum that it doesn't matter. But most of the ones I see have like between 10 and 20,000 is the minimum. And then there's often early termination penalty clauses that if you get out of the contract, since it's a multi-year and they may have given you some infrastructure loans up front, there's penalty clauses on repayment sometimes of those infrastructure costs, or you don't get the shared savings. Sometimes they prorate it. One of the risks here is if there is an early termination penalty clause and the payer comes out with a new improved model, unless you have specific language that addresses that in your contract, you might be subject to that penalty. So the point of that slide is you have to look at the whole contract. You can't just look at rate pages. You have to understand what those other pieces are that the payers have available. On page 16, not all reimbursement provisions are in rate attachments. There's a definition of contract and inclusion of provider manuals. We've already talked about that. They can almost always be amended or updated at the payer's discretion and usually do not require approval prior to implementation. So it's usually, here's our change. If you don't like it, you can terminate. And that's not usually a good option, especially if they're one of your larger payers. So, and then the other part is if they do those, and depending on your termination provisions, you might have to operate under those changes for a period of time without recourse. So those changes could become part of a contract, and if your contract required you to give, a 180-day notice prior to the end of the current term, and you just re-signed, you're going to be living with those changes for a good period of time. I do need to point out that some states have regulations around notification of updates to provider manuals and policies. Some require that they tell you exactly what has changed. It really varies state by state, so make sure you understand what your state requirements are. Some of them actually have penalties if the payer does not provide notice. On the next page, we have the other part is where the contract language sometimes hangs out, are the obligations of payer, obligations of provider, or compensation sections. That's where there's other language that has like the claims filing limits, authorization requirements for payment, adjustments, offsets, appeals, claims processing rules, rate protection, and penalties. All of those pieces can impact on the amount of revenue you achieve out of contracts. So these are pieces that you really need to understand. Usually in the contract, they're not detailed, they're very vague. They often refer to the collateral materials that we've already talked about. And all of these are the levers that they can move to impact reimbursement. So, I frequently, when I do, payment analysis, I'll look at the actual contract rate and see, we're supposed to get 100 and whatever percent of Medicare. And then when you look at the actual, it's much lower than that. And that's because they've applied some of these rules on a procedure by procedure basis to effectively reduce the total net. On the retrospective payment models, those include most payer-offered bundled payments and shared savings models. They may be a separate contract or an amendment, or sometimes they're simply a section or a clause. If you see them as a section or a clause, I'd be a little wary because that means they haven't put a lot of thought into it. And those usually are more open-ended and the payers have a lot of leeway. So the attributes of those kinds of models are things that we've already talked about: the attribution model, quality and efficiency, the defined calculation process, required organizational structures. So this includes who can participate and who can't participate, and what those organizational structures in terms of, are they an ACO or a CIN or some other entity. Some of them are very prescriptive in terms of who can participate, without understanding that you can have a different name for an entity that has the same function, and they should be able to participate the same way. So I try to get payers to get off of using specific language. And then there's the shared savings calculations. The risks are, minimum panel sizes, retroactivity, the coding. On the measurement processes, specifically on quality, do they use a ranking versus actual? So one of the large payers actually ranks you in terms of how you compare to your peers, and that drives the shared savings amount. And when that happens, you could be doing everything right, but somebody who was doing not very much right the year before could have improved significantly more and pushed you out of your ranking in your share of the shared savings. Same thing on benchmarks. Sometimes they have local. They compare you to, I frequently see in contracts that we will compare your measures to yourself, to local, to some national benchmark. You need to understand what those are, because when they have that language, actually it's usually not, it's usually at the discretion of the payer, and it could be any of those, and they're probably going to pick the one that makes you look the worst. I haven't seen one yet where they actually pick the one that, the best. Defined calculation process, definitions of inclusions and exclusions are extremely important. There are a lot of places in different processes that they can exclude certain services, have you at risk for things that you don't have control over. So that gets also to the coding level. You need to understand it at a code level and what services you provide. Audit capability is a big issue. Lack of real claims data. A lot of payers, because of FTC concerns or contractual language in existing contracts, or just market, not wanting to participate, they sometimes use averages or they use proxy data in terms of the cost. And therefore, if you're doing a shared savings and it's a reduction in actual cost, you actually can't audit that data, and that's an issue. States handle it differently. In some states, in some contracts, there's language that says that a third-party auditor has access to all the data and attests that the payer paid everything right and did it right. And it's usually an independent auditor that has additional costs because you have to pay part of the cost of the auditor. So there's different ways to do that, but we need to get to the point where we actually have the actual cost so that we can guide that care in order to really have true cost reduction. The required organizational structures, affiliate entity structures, and downstream contracting. Oftentimes I see entities trying to come together and it turns out their bylaws or affiliation agreements prohibit them from participating. So you start to build and then have to step back because there's legal issues that need remediation on an entity that you may or may not have control over. Shared savings calculations, one of the biggest concerns I have in some of these contracts that I look at are the loss carry forward and recalculation process. So there can be retroactivity on eligibility and attribution, where they actually can go back into future, so you finished performance year 1, you're in year 2 or 3, they'll go back and recalculate 3 years back based off of new claims that have come in. So that's a risk that when I counsel clients, I try to get the payers to get that language out of the contract. The payer provider manuals, policies, and newsletters. So the days of 20 to 40 page provider manuals, back when I started, they're gone. They're now like 100 to 400 pages minimum. Most of them are now on websites. Some have restricted access. The web versions are especially challenging. There's typically multiple documents. There's manuals, clinical guidelines, policies, newsletters. It's usually the search function doesn't work very well. There's restricted access. This restricted access limits sometimes what you can actually get into. It's also, they're usually segmented by provider type. So there's a section for hospitals, a section for physicians, and that if you're doing an ACO where you're responsible for the total cost, you can't see what is being told to both of those parties, even though both parties may be part of one of these contracts. Updates are made, but changes aren't usually flagged on websites. Some payers they update their website structures at least twice a year, making it more challenging to find information. And many of the payment and process rules that affect how claims or bonuses are paid are located in these documents and not the actual contract. So the next part is how I recommend you do a contract review. And the first thing is before you even start, you have to understand your entity's structure and capabilities today, and you have to be honest. We do assessments. Sometimes we send out something in advance and ask them to rate themselves, and they tell us they have, oh, we have all this great stuff. And then when we actually talk to them, they back down a little bit. So you're not helping yourself by not being honest. You actually have to understand what you have, how robust it is, and whether it's functioning the way it should be. You need to know if there's structural issues that exist that may prohibit your affiliated entities from entering into contracts. So examples are ownership relationships like JVs, bylaws, and operating agreements. You need to understand what those are of all the entities that you want to bring together under some of these shared savings contracts to make sure that there's no issues. You have to understand your capabilities, and these are the main ones you need to understand: the care management, care transitions, your IT infrastructure, financial analysis, performance tracking and reporting, and the processes in place and timing of capability modification. So you can't be so cumbersome and have such a bureaucratic process that you can't quickly respond, because what the payers are looking for are people who can quickly respond to issues and make the changes to advance it. Otherwise, you're going to get left behind. The other thing is you need to understand your current quality and efficiency metric rates by payer segment. And by segment, I mean by PPO, by HMO, by Medicare, by Medicaid, so that you have that data, and when they come to you with targets, you know where you stand right off the bat. So on page 21, and this is where I usually, when I'm doing these live, get a little gasp. I always tell people, before looking at the rates, read the contract and catalog the contract capability requirements against what you just did on the previous page. Determine if you can comply with those requirements and with the current structures, processes, and staffing levels. If your entity falls short and you can't meet those capability requirements, determine an estimated total cost of developing or purchasing those capabilities or improving revenue-related metrics as this cost needs to be taken into account when reviewing the rates and overall financial impact. So you can't just sign a contract and stick it in a drawer and hope for the best, which sometimes I hear that. We signed it, we're going to wait and see what happens. That's not a good way. There's too much at risk with these contracts. You need to review and catalog the base contract reimbursement provisions that may not be in the rate section, so look for those pieces in the other sections. If you don't have the latest provider manual, policies, and newsletters, request them or get website access from the payer so you can review those along with the contract. It's a good idea to look for variances between the actual contract language and what's in those collateral materials because they don't always match, and those are points that should be discussed and negotiated. And always keep in mind that there's usually a clause in the contract that specifies what the controlling document is. And it's usually the latest contract amendment or collateral material available. So just because you have a contract that says one thing, if you don't keep up with the updates in this other material, you're going to find yourself in a position where it's not defensible, and it's not, if you took it to arbitration, you would most likely lose because there's usually this controlling document clause. Then review, once you've identified what those capabilities are and identify what's going to cost you to comply with the contract, then review the rates in the total package, taking into consideration the costs identified in the requirements and any effect that payment policies will have on the rates. Special provision review, I've added this slide because there are certain things that I just want to point out on some key points on some of the different models that are out there. So on shared savings, there's always a target per member per month with the sharing of a pool. If efficiency metrics and quality metric targets are achieved, some models require achieving all of the metrics and the targets in order to get paid, and by not achieving those targets, you get no part of the shared savings pool. Some have a reduction factor based off of a percentage. They do it different ways, so make sure you understand that. In reviewing that impact, you need to look at the reduction in revenues due to those efficiency metrics and the reduction in utilization and reduction in services and compare it. So if they're asking for an efficiency reduction in, say, high-tech imaging, from X per thousand down to Y per thousand, what is that impact on your fee-for-service revenue, and understand how that relates to what the shared savings, potential shared savings amount is, to make sure that you're not in a negative position. Retrospective bundled payment initiatives, there's a flat payment amount. Sometimes it's risk adjusted, sometimes it's not. That's used in a reconciliation. Actual paid claims from claims based on a specific trigger event are total per defined methodology to see if you met the rate. And there's typically a sharing of savings or a loss as applicable. These are usually in services that there's the clinical variation should be minimal. There shouldn't be a lot of clinical variation in those procedures. If you have a lot of clinical variation, you probably shouldn't get into those bundles because that's what it takes to be successful under these. And they're best evaluated on a bundle-by-bundle basis to determine impact on your revenues for a specific payer. They all have different methodologies in terms of what the triggers are and what's included. Capitation, if someone's offering you a capitation, you need really actuarial analysis to determine feasibility of the rates for the select population services. Requires analysis of all current claims payment data to determine that impact. And on capitation, remember that the ones today are not like the capitation of the 90s. Most of these, the payers retain claims payment. So it's a paper financial transaction instead of you actually paying the claims. Ongoing compliance. Contract is a formal document that details a relationship between the parties. And relationships take time, commitment, and vigilance to be sustainable. So, best practices, you need to develop competency and evaluation of contracts. Understand Don't hesitate to ask for clarification on intent, and don't make assumptions on what you think that intent is. It's always better to ask and be clear. Develop a list of contractual provision language acceptable to your organization. So set your parameters. Know what you can totally live with, or what are deal breakers. Besides reviewing language presented, look for missing provisions and question intent of omission. Sometimes they do it intentionally, and then it's vague. I have mixed feelings on whether a contract should be specific or vague, and it really depends on the trust level with the payer. But I always usually I prefer more specific, so that you totally understand what the rules are. Understand explicitly the requirements and impact on failing to meet those requirements. Develop a payer contract committee and a contract compliance team. Contractual provisions affect your entire organization at different levels, and the obligations cross multiple areas of expertise within your organization. So you really need an interdepartmental contracting committee to ensure that the organization understands requirements and can drive the required changes, process changes. So you need decision makers, people that can affect process changes to be compliant. Contract compliance and tracking also needs to be interdepartmental to mitigate any negative trends. So you need eyes and ears outside of the CFOs or the CEOs to identify what's going on with specific payers, and your organization are your eyes and ears. So they need to be, which goes into the next point, they need to be socialized on what the contract means. So, the organization has to understand the importance of the relationship. After all, these contracts are your revenue source, and they have to have ownership of the processes and the ability to identify and surface potential issues. So, everyone in your organization needs to understand the contracts, not all at the same level, but they all need to understand how they fit into that piece and be able to respond and let you know if there's something wrong. So my last slide is the more contracts you have, the harder it will be to manage them without a structured review and monitoring process. All the payers have different structures, contractual requirements, and they're sometimes at odds with each other, especially on the quality metrics. They use different versions. They update them differently, and managing that is extremely cumbersome. So you sort of need to decide where you're going to focus. I tend to, when I do an entity contract analysis, I focus on those elements where that create the most value for the organization. And the value can either be revenue, so if there's certain metrics that the reimbursement is higher for, or it's a tiering or a quality-based issue on public perception. Those are the ones where the most focus should be placed. And that does require that you understand and quantify the revenue and the rating impact of the metrics in order to prioritize compliance efforts. One of my clients, we just did a review, and in one state they had like 650 different quality metrics that had to be tracked. And that's a huge ask and a huge lift for any hospital system to be able to provide that and do it well. So you need to figure out which ones are most important for you as an entity and what the impact is. And that wraps it up.
Great. Thank you for the very insightful presentation, Debra. We do have time for a few questions. So again, for those who are logged in, if you have questions you'd like to ask of Debra in the time we have remaining, feel free to submit via the webinar interface. Just type in your question and click send, and we'll keep an eye out for it and see address as many as we might have time for here in the remaining time. So we do have a couple to kind of get started with. So first off, you mentioned you talked quite a bit about attribution models, and just curious, what is the best attribution model from your perspective?
So the best is where we have a selected or an assigned primary care physician typically found in HMOs. It's beginning to show up in PPO gated products. Cigna has a lot of gated PPO models. If the products that you're participating in aren't gated, ensure you understand the methodology. And it's usually a variety of steps. And understand who the physicians are that are tied to that contract, because you may get attributed lives from physicians who, due to however the payer has it set up, physicians that aren't actually affiliated with you. And then you're responsible usually for submitting quality data and or being responsible for the cost of care, and you don't have control of that patient.
Thank you. With regard to capabilities, I wonder if you can give some examples of what you're seeing in contracts currently.
So there's a lot of variety. There's, care managers, and that's a staffing cost. Sometimes the contracts say you need this many care managers for this number of attributed lives. And then there's expectations in terms of what those care managers will do, and the payers actually come in and audit. There's patient-centric registry. That's an IT piece, and it's very costly to purchase, maintain, and train people on. But those have your clinical guidelines and your benchmarks for you to do reporting off of. They usually have to cross all of the participating providers. And it's designed primarily to make sure that you're meeting the quality metrics and that there's not patients that are falling by the wayside. Things like patient-centered medical home, some contracts have that. They often require you to have a certain level of NCQA certification, which means you have to expend some funding, some dollars to get that hit that certification, because NCQA has to come in and audit. The quality metric explosion, that's huge. Just understanding what those coding requirements are and making sure that they're everyone that's affiliated with this contract understands what those coding requirements are for you to achieve those results. Frequently they use the HCPCS codes, and a lot of providers don't actually bill those out, and that's how they calculate. I think probably quality metric scores are underreported by probably 25 to 45%, just because people don't understand what the codes are that are driving it. Less apparent are financial and analytics required to make sure you're on track. You need to track the contracts, hopefully using the same methodology that the payer is, to make sure that you aren't surprised when the performance period is over.
Thank you. I have a question just looking to clarify. The question is your sense that payers are less likely to offer a value-based contract lately? Is that the trend, or is that the movement you're seeing? Can you clarify?
We're seeing that in markets where the providers, so it's in markets where there was value-based and the models weren't as successful as the payers thought they were going to be. So they've pulled back a little bit and moved people to fee-for-service with pay-for-performance instead of shared savings. And part of it is it's in models where it's in areas where there's a lot of PPO, and the whole PPO HMO thing is sort of cyclical. People go back and forth as to what they want. So it's where there's a big PPO. It's really hard to control costs when you have open networks where patients can go wherever they want, and an entity is responsible for shared savings. So, out in Southern California, there's a lot of HMO lives, same thing in South Florida. They are still pushing value-based models. In other ones, they are retreating a little bit and just offering a fee-for-service with a pay-for-performance.
Great, thank you. One more question. Just curious, coming back to your comments earlier about who's taking the lead on driving the movement towards value and the contrasting dynamic that comes into play there. Can you maybe elaborate in terms of the instances where you've seen providers taking the lead and kind of approaches they've taken and success factors that they've had that others should be mindful of maybe?
So the where providers have it, you're talking about like your big systems, Geisinger, here in Chicago, Advocate, those kinds of models where they have a culture. First of all, they have highly aligned physicians who are all working under the same sort of model. Even though you can have independent, but they all bought into the concept, and they're able, because they sort of have control over the system and they believe they have control over their destiny, to define this is what's working for us, and will you participate in it? There hasn't been a lot of that in most of America. I mean, actually, to be perfectly honest, most of the markets I go into, it's almost all still fee for service, and in probably 70% of markets I go into, it's still a percent of billed charges, which totally floors me because that's totally not value-based. So it's where you have that alignment. You really need to have everyone working towards the same goal, and the incentives need to be aligned. So your physicians and the health systems, hospitals, need to be on the same path, because without that, you have to have good collaboration. There has to be excellent communication between those two parties. They need to be developed together, and those are the areas where they have more success in developing their own programs and pushing their own programs. There's been some markets where they've tried, like Southern California. There was a group of entities that came together and tried to say, this is how we're going to operate with the payers, and we're going to form this alliance. And it's really hard to get, multiple entities that have different operating models to work together towards one common goal, mostly in those large, sort of homogeneous, aligned physician hospital organizations where they have most success in driving new benefit designs and in new payment models. A lot of what's happening right now is being based on the CMS initiatives out of the Innovation Center. One of the things that everyone should be watching is the CPC Plus. It's not in all the states, but in the states that it is in, there's a large number of physician participants. And the interesting thing about that model, and there's another one in the Innovation Center, that required payers to participate, to apply, and once the payers applied, then the physicians applied. And the payers had to agree as part of this to sign a contract with CMS that says within 3 years they're going to be offering those kind of payment models to all of their lines of business. So here's where CMS is through the back door getting into commercial payment structures. So, one of the things, and what commercial payers do, to be perfectly honest, is they go and they look at how these programs are structured, and they pick the pieces of it that fit within their legacy system to drive forward. So it wouldn't be a bad idea for people to look at the CPC models. There's 2 tracks. It's a fee-for-service with sort of a withhold with or reduced reimbursement with a shared savings at the back, and there's 2 tracks. So I can see they're in, it started January 1st, so they're in the first 6 months. But that's going to be, in those states where that is, I'm hearing a lot of requests from payers to start modifying contract language that actually is more in line with what's in that model.
Great, thank you for those insights, and thank you again for an excellent presentation. We're at the top of the hour here, so we're going to go ahead and wrap up. I want to thank our attendees for joining us. Hope you found this presentation very valuable, and we welcome additional questions that we may not have covered here today. You can reach out to Debra directly at the email address indicated on screen there. Also want to mention that Debra, as well as several other Kaufman Hall colleagues, will be at the HFMA A&I conference in Orlando later this month. So if you or a colleague happen to be attending, feel free to stop by our booth or reach out. We'd be happy to meet with you privately to talk further about contracting or other issues related to clinical variation management. We have experts who will be there to address that topic as well. So please let us know. We'll be happy to talk with you. Feel free to access the article shown on right there in your handouts. And if you're interested in receiving a copy of the presentation, we'll be happy to send that to you as well as a follow-up to today's webinar. So again, thank you for joining us, and we will talk to you again soon.